Welcome to our webinar about Parkinson's and stigma. I'm Casey Peluso from Parkinson Foundation, Western Pennsylvania, and very honored and grateful for our two presenters today on this, I'd like to say, more of a cutting edge topic. I would like to introduce you to Dr. Indu Subramanian. She is a board certified integrative medicine doctor. She's passionate about palliative care and stigma and effects of loneliness on people living with Parkinson's. She is the co-chair of the Wellness Task Force and at the Movement Disorder Specialist Society and chair of the Movement Disorder Specialist Section at AAN. And we have Dr. Brad McDaniels. He's presented some webinars in the past, and he is an assistant professor and program coordinator for Rehab Studies program at the University of North Texas. He has done his doctorate training at the University of Kentucky, postdoc research at Virginia Commonwealth University with an exclusive focus on Parkinson's. And he is very passionate about Parkinson's and has been conducting research about meaning in life, loneliness, demoralization, stigma, and other non-motor issues of Parkinson's disease. So thank you, Dr. Brad and Dr. Indu, and please take it away.
All right. Thank you, Casey, for that kind introduction. Nice to be back with you all again. It's been several months since I've seen you, so always welcome the opportunity to come back and share our research, and excited to have Indu with me today. She and I have been working together for a couple of years now and have been having a lot of fun writing about some of these topics that, you know, we believe need to be talked about in the Parkinson's world. And, you know, it's important to bring some of these things to light so we can begin to understand how much they affect those with Parkinson's. So let me share my screen and we will get started. It looks like this one. Can y'all see that one?
Yeah, looks good.
All right, perfect. So this is Staying Hidden, the Burden of Stigma in PD. I was sharing with Casey before we got started that the timing of this is perfect. We had, I guess when I had agreed to come do this talk several months ago, I knew that this was in our queue of something that we were going to be working on. And it just so happens that it hit press, I don't know, 2-3 weeks ago. So this is brand new information and certainly much needed. So we'll jump right in. So here are the objectives for today. We're going to understand what stigma is and why it matters to people with PD. I think you all probably have an idea of what stigma is and probably have experienced some, as most with PD do. But we're going to dig into that a little bit. We're going to understand the effects of stigma. What does it mean if you experience stigma, and why do we care, quite frankly? And then lastly, we're going to learn some tools to lessen the effects of stigma that can hopefully help you deal with this struggle as you're working through your Parkinson's. So Indu and I will kind of tag team. We'll go back and forth as we go. So we will go ahead and dig right in. And considering this is from Indu's work, Indu, I'm going to let you begin talking right here on mental health.
Sure. Great. So thanks, Brad, for the intro, and everyone else for being here to hear about this important topic. It's near and dear to our hearts. And I think a lot of folks have felt stigma even before this, perhaps in other ways, before getting the diagnosis of Parkinson's disease. But I think, you know, just thinking about Parkinson's disease, generally it's thought of as a motor disease. But as we know, taking care of people living with this and you living with this, it's really not just a motor disease. There's this huge non-motor burden. And within that, there's a huge mental health component as well. So things like anxiety, apathy, depression are really affecting a lot of people living with this. And so, you know, in the pandemic, I think we saw that there was a burgeoning problem with this mental health amongst all of us, with the isolation and grief, trauma that many of us felt during the COVID-19 pandemic. But I think it really did reveal a number of problems that existed within our healthcare system and the sort of archaic model of healthcare delivery, in which I sit in a ivory tower, UCLA, for example, and you have to come and see me. You complain about something, I write down that complaint and bill for that complaint, and then you go home and come back in 6 months, is really, I don't think, serving most people living with this disease very well. And really, we have a number of caregivers that have really been stuck at home, often very isolated through the pandemic, and are just only now coming out, to sort of seek help and get some respite. So I think that is also a contributor to the barriers to getting care for mental health. And there's really a lack of disease awareness. So many people just think of Parkinson's, as I mentioned, as a motor disease, not really thinking about these other aspects of it, which are really, study after study show that mental health and these non-motor issues affect quality of life more than even the motor symptoms. We have a scarcity of mental health resources. And then unfortunately, there is a real disparity in terms of who tends to get issues with this, and it's already the minoritized populations, depending on racial minorities. Women tend to suffer more with mental health consequences. If you live in rural places, if you have socioeconomic issues, these are all reasons that you can get more mental health problems and have even more barriers to getting help in this time frame. And then stigma, which we're going to focus on, is also a problem. And Brad is going to define that, and we're going to tease this aspect out a little bit more throughout this talk.
So this is some work that Indu and I did with Greg Pontone and Adrian Keener. Adrian works with Indu at UCLA. And we were looking at a variety of challenges that are associated with Parkinson's disease. And this is one of the figures we came up with. And we know that there are a variety of psychological challenges that people encounter upon diagnosis, right? There's a lot of fear, there's demoralization, which is kind of like the inability to cope, right? You're really not sure what to do. You've got this psychological distress going on, and you really don't know how to move forward. And one of the things that we talked about in this earlier paper was the role that stigma plays. And, the more stigma that one has, the lower quality of life we're going to see. And we're going to talk about really why that is, and what are the things that come into play, and how does stigma relate to loneliness? How does stigma relate to depression, to demoralization, all of these other things? And it really is going to perpetuate the problem, right? It's just going to make it worse as one begins to experience stigma and face the challenges associated with it. So we thought this was a nice graphic representation to help you understand all of these things in the upper right-hand corner that are problematic and certainly contribute to issues with PD. So I always think it's important, before we dig too much into the meat of this topic, that we're all on the same page for what we're talking about. So you go to Merriam-Webster and you type in stigma, and this is what you're going to find: a set of negative and unfair beliefs that a society or group of people have about something. We can even elaborate that something or someone, right? B is a mark of shame or discredit, and the synonym for that was stain, and an identifying mark or characteristic. So, right, you think about this and you view a picture that you see of someone with Parkinson's disease, right? And Indu has been talking about this old picture of Parkinson's disease, right, that you guys have all seen in the literature: picture of an older white man hunched over with a walker or using a wheelchair. And the mental image that brings up, and the emotions and the beliefs that are associated with that picture, are really problematic. And it's been talked about. Mike Oken has talked about this through some of his work as well. So we begin to see that there's a need to begin this shift to what stigma or what Parkinson's disease is and how we look at it. So let's look at some other things. We've got Merriam-Webster's definition, but I think it's important to also consider a contextual definition of what we're talking about with stigma. So the first one is, it's been around for a long time. The ancient Greeks used it as a mark to be able to identify people whom they wanted to shun, who had done something wrong, who had some immorality in their life. Many of you probably remember the book, The Scarlet Letter, right? That was a way that you could identify someone who had committed adultery, right? And so this thing has been around to really separate groups of people for many, many years. You've got the in group and the out group is really what you're looking at. Another way to look at it's an attribute that's deeply discrediting. And so it makes one feel less than whole, right? It's one characteristic of who you are as a person, but that can become really who we are. And that's where stigma really begins to be problematic from a mental health perspective, because it takes over our personality. And that's what we're focused on always. It's an undesired differentness, and it separates you from normal society. So it's something about you, i.e. tremor, gait abnormalities, dyskinesias, right? Things that are all associated with people with Parkinson's disease that others in society can pick up on, they can notice, they can question what's going on with that person. It's something that's different, right? And normal society, I'm not really sure what that is, but that's from someone who doesn't have a disorder is probably a better way to put that. But that's Irving Goffman. He's the guy that is widely credited with beginning the study of stigma in chronic illness. And then there are these terms that are all associated with stigma: labeling, stereotyping, some type of separation. It's always us and them, right? And one of the things that's important to understand is it always occurs in excuse me, in a power situation. So what that means is you've got one group who has power over another group, and they can influence them as far as disempowering them, having them not have a say in society, in their life, in their decisions, even from a medical perspective. And I'm sure Indu will probably talk about this a little bit, but it's not uncommon that physicians in our country will have beliefs about people who come in to see them, right? Right or wrong. I think it's part of what we deal with. So it's not just people in our society who are uneducated who have these beliefs. There are plenty of really educated people who may have a misunderstanding and certain beliefs about someone with Parkinson's. Now, this is a really busy slide. I'm not going to spend a lot of time here, but this came from another one of the papers that we did, or the stigma paper, actually. And we had put together a graphic that we borrowed from someone else who had some similar stuff in it. And it really just gives you a snapshot of how stigma affects people with Parkinson's disease. And you can really fill in the blank, whether it's Parkinson's or anything else, the model still fits. That you've got these structural facilitators that are in our society, right? You've got media. How does media portray Parkinson's disease? What about healthcare? What about the workplace? And then what about family, friends, people you run into at work, healthcare providers? All of these people contribute to how stigma affects the individual and how it's viewed by a larger society as a whole. So then we've got that. We also look at what is it within us, right? The biological piece. And that's the simple one. That's tremor, dyskinesia, gait abnormalities. But then what's the belief that's associated with that? That's really where the struggle comes in. And that's where the world of counseling and psychology comes in to help, is we can reframe those beliefs that someone has. We'll talk a little bit more about that later. But these ideas of blame, of shame, anxiety associated with whatever these stigmatizing beliefs are. And then there's the social, what do we get from those around us in society? We'll spend some time in a couple slides looking at public versus self-stigma, breaking those down. And then at the end of the day, the column on the far right is really kind of the so what, right? What does it mean? It's great that you're going to tell us about stigma, but how does it affect our lives? And these are the ways that it affects you. And we're going to delve into these along the way and talk about the mitigating factors. What are the things that we can do to help lessen the effect of stigma on people with PD? Went too far. So let's just briefly talk about types of stigma. Health-related stigma is really kind of the overarching term that we think about when we're talking about stigma. And it really is all of these things that can discredit an individual. And it's what we talked about with Parkinson's, with, the tremor, the dyskinesia. What are those things that disempower me? What are those things that make me feel less than? What are these things that make me feel shameful? And then what can I do about them? And underneath that, there are, if you read a lot of literature on stigma, there are a variety of types of stigma that are talked about, but they really fall into two buckets. And the one is public stigma, which is really that part of stigma that is in society, and it's what the way that people are viewing you. It's cultural, it's social, and it are those cognitive beliefs that people have about a given group, whether it's people with Parkinson's or people with cancer, people who smoke, whatever those things are. And it's these things that can trigger an emotional and behavioral response. So you might feel an emotional reaction to, got a slide coming up, someone who you find out has lung cancer, right? It's one of those stigmatizing conditions in our country that the assumption is, what have you done to deserve that? That's usually the first thought that people have. You smoked, so you had a choice. And, stigma is always worse when someone is viewed to have a choice about whether or not they have the problem. And which obviously isn't the case with Parkinson's, but that can be an educational issue as well, right? So the public stigma is what these negative attitudes that the general public, healthcare providers, others hold about a given group. And the real problem begins when anticipated or self-stigma happens. And really what that is that's when one begins to internalize these beliefs. That someone believes that an individual who has Parkinson's disease is less competent, let's just say. And if you begin to feel that, you can imagine how that's going to impact the things that you engage in your life, right? You may be less apt to be involved in social settings. You may be less likely to go to support groups, and probably loneliness will ensue because you want to avoid. And avoidance is a coping strategy that many people can use, but it's not effective in the long run. So it's really this piece of self-stigma that is the one that affects us the most. And it's really where we're going to focus most of our time today. And I just gave you this picture. I thought it was interesting, right? And this is an example of self-stigma. It's looking in the mirror and what's the reflection that you see? And part of this is triggered by the emotional responses that we have in our mind, what we think other people are thinking of us. And I tell my students all the time who are wanting to be counselors, I say, you don't have any idea what your clients think about you, and they don't have any idea what others think about them. But yet imagine through our lives how often we make decisions about what we're going to do or not do because we think we know what someone else is thinking, right? It's a very dangerous place to be because it's not true. So it's really getting a picture of yourself that's not holistic, and that you're just looking at specific features and having them define who you are. So a couple of quick things. What comes to mind when you see these? I already mentioned the one, right? These are three conditions that are highly stigmatized in our country. They continue to be. HIV and AIDS, we went through a time in the 80s, right, when that was brand new and there was so much missing and disinformation about what the condition really was and what it meant, how it was contracted. And it's gotten better over the years, but there's still that piece of stigma that's associated with that you want to avoid someone who has HIV. There's the disinformation that if I shake hands or hug them, I can get HIV, right? A lot of that was perpetuated in the media and just false beliefs. But all three of these conditions that we're looking at here are stigmatized largely because of one reason, is that they're viewed that the individual did something to deserve the condition that they're in. And that certainly contributes to the effect of stigma on individuals. Is did you do something to deserve it? And also concealability is an issue, right? Someone who struggles with obesity, it's really hard to conceal that, right? To hide it. You can try to dress in baggier clothes and look bigger, but there's really no way. Versus someone with lung cancer, you very well might be able to hide that. You may have some coughing and some issues with COPD or other types of things, but you can largely conceal that, and it doesn't necessarily come across as stigmatizing. But I thought to show those pictures, I know everybody who's here today had a thought that went through your mind when you saw these. And that's what we're dealing with stigma across the board. Indu, do you want to talk about this one?
Yeah, sure. If I may, Brad, maybe we could just go back a couple of slides. I just wanted to point out one or two other things. Just go back.
Wrong way.
Yeah, this one. So just to point out a couple things here. So I think that Brad had outlined a number of things that were pretty important here. But I think that even though we talk about some of these things as sort of a historical feature of how maybe the HIV pandemic was in that time or epidemic. I think that in some parts of the world and some cultures, some of these issues still are perpetuated even today. We met some of our African colleagues, and they said that in Africa, there's a thought that Parkinson's people who are affected by Parkinson's have been possessed. There's some witchcraft involved. Perhaps they did something to deserve this, and sometimes they're hidden as a consequence. So I think this can have real life and real world consequences in a very real way in other parts of the world, but certainly in smaller ways, perhaps, or even in bigger ways in some cultural contexts, even amongst us here. One of the things that I wanted to point out is this to the far right, this issue with medical access and utility of the medical system. So sometimes when there is a sense that the physician themselves may be clueless or not clear about why you're presenting or you don't have a good rapport, and there is a sense maybe that you have stigma even with the healthcare system that you're dealing with, it leads sometimes to patients not having trust. It also leads to people feeling like they don't want to come back to see us as physicians. And so I think we have to be honest about that and address that head on. And sort of if there are these interactions and you're feeling uncomfortable, I saw a message in the chat about somebody who felt uncomfortable with some of the messaging that they were getting from their doctor and ended up switching. I think there are many options, and certainly, I think you can find people that you can have more rapport with, or you feel less stigmatized around, or can, be more easily accessible. So this can actually really affect even the care that we have with our patients within our own health system, because the sense is they don't come back, they don't take the medicines, they don't, follow through, and then they're labeled as sometimes even a non-compliant patient, which is an additional sort of level of stigma that I think is really troubling. And another thought that I had as you were going through this, Brad, was the sort of role of, not just media, but social media as well, and the sort of sense of perfection, that everybody else has a perfect life, that everyone else is whole and perfectly well and healthy. And many of our people living with Parkinson's are actually, doing really well in regular society and have, controlled symptoms early on in disease and are doing, many great contributions, and they aren't coming forward to say that they have the disease. And so often the people that are labeled, or we sort of come to mind as that sort of image of somebody who's quite disabled and really, somebody who's living in, a nursing home or needs care or something like that. So I think we really have to sort of dispel the sort of images that we ourselves have been propagating of some of this. And the other thing I'll say is that, another layer to the stigma that, because of that older white male image, is that, there's sort of an automatic sense that it's an old person that's getting Parkinson's. And when people get this disease, they sort of feel associated with that group that is old. And then, in our society, we really have an ageist society where as people age, sometimes they aren't valued. They don't feel as contributing members of society. And they are really, sort of stigmatized just for being older by some of our younger counterparts. And so I think, it is something that we have to also address, is that there's sort of this association just with the age, and that adds another layer of stigma. So, just to sort of point out some of the nuances of the slide, and then we can go to the other one that you wanted me to try to address.
Yeah, and Indu, on that, you were talking about these, the older age, and we talk about that in the paper, that this is a double stigma that many people face. Right now, you've got Parkinson's. Now you're also part of the aging community, and you've got stigma there. If you're a minority and you've got Parkinson's disease, there's double stigma, right? So there's all of these things that just compound on one another and can really affect outcomes in people with PD. So
absolutely. So we have the sense that the public has an image of us, and if we have any sort of medical condition, often, and then there's a sort of self-inflicted, then the sort of double, the second sword, is that what it was, or something like that? It's like the sort of double hit that really is the one that knocks us out, I guess. So in sort of speaking about this, there's sort of the public stigma of, there's a sense that there's people that are maybe incompetent or can't do things, and are disabled. Then there's sort of this negative emotional reaction. People feel pity, fear, maybe disgust, depending on what the issue is. And then there's this sort of folks that, then respond to that by being avoidant or social distancing. And I think that, many people who tell me about their Parkinson's experience, and sometimes the fear of telling other people about the diagnosis, is that they're worried that they're not going to get support, that their loved ones are going to turn on them. Certainly in, for example, the culture that I live in Indian culture, there's a real shame sometimes with having a family member with something like a health problem. And people only want to talk about the good times or the positive things that happen, and who went into med school and who got married to the six-figure, or whatever, millionaire. So when bad things happen, people really don't discuss it. They often tend to hide things. So then on top of that, then there's this sort of negative aspects that we then put on ourselves. So, there's a sense that, yes, I am in fact, weaker or disabled, or that I'm not whole, that I do merit this sort of pity. And I am sort of, I feel insecure, my self-esteem goes down. And then there's a sort of sense that nobody wants to be around me. I'm a burden to society, and my family doesn't want to, take me out because they're embarrassed by me. And I'm just going to stay at home and isolate from, my community, or isolate from my family. And in fact, talking to many family members of people living with Parkinson's, they often feel the opposite. They want to spend time. They want their grandkids around their grandparents. They want to take them and enjoy them at family functions. And they hate the fact that their family doesn't want to come out anymore. And so it's really this sort of odd sort of sense that you are not wanted or undesirable, and really the opposite is true. So I think, working through some of these thoughts and really helping to understand, that sort of elephant in the room, I think is really important.
Yeah. And so we'll quickly go through this. A lot of this stuff we've talked about already, but these are all of the things that stigma can result in, right? Poorer mental health outcomes. And I think I've got depression on this list, but depression, anxiety, demoralization, self-pity, increased psychological distress. Clearly, there's an association with that. What are other people thinking? I can't do this because this will be the outcome, right? Poor physical health, poor quality of life, decreased levels of hope. We know the role that hope plays in positive outcomes for people with chronic illness. And when we begin to lose hope, the outcomes just continue to go down. Poor self-esteem. I don't feel like I am worthy. I'm less than because I have this condition. I'm broken, right? Poor self-efficacy. All that is do I think I can do things, right? And that's one of the biggest challenges, I think, that of the stigma with the self-stigma with PD, is over time, people begin to feel like maybe they can't do what they used to do, which is real, right? But there are still things that we can do, right? There still are things that you can engage in, types of exercise. So it's about learning that maybe the things I can do change over time, but I still have capability to be able to do many things. Increased levels of stress, right? Stress makes tremor worse, right? We know this. So you've got stigma, you've got increased stress, you're probably going to have some increased physical symptoms of your Parkinson's. Increased social isolation, right? We've kind of talked about that. It makes sense that you're going to potentially avoid wanting to be around other people because you're self-conscious of your Parkinson's. So Indu, I'm going to let you talk about this, especially with, maybe what are the things, the physical symptoms, how that affects Parkinson's, all that stuff that you see in your own clinic.
Sure. So before we leave the piece on social isolation and loneliness, so Brad and I have published some of this work, but I think there's been a lack of understanding historically of how impactful loneliness is on health. Loneliness is worse than smoking half a pack of cigarettes or being obese, and it really can have a lot of healthcare outcomes just in general in terms of increasing morbidity and mortality, so shorter lifespan, things like that. In the neurology world, it can increase our risk of dementia. And there was just a paper that showed that being lonely actually increases our risk of getting Parkinson's disease. This is like really hot off the press data. And in our own studies, we showed that being lonely had the negative effects of being lonely were, the sort of greater than the positive effects of exercising 7 days a week for 30 minutes a day. So really, a pretty dramatic sort of game-changing issue. And so, if we can prevent that consequence of stigma and all the things that come with it, I think we're really trying to kind of be proactive about trying to do these sorts of things because we know that it makes a difference in motor and non-motor issues and quality of life in Parkinson's. So more than 50% of people living with Parkinson's try to conceal their disease. And you're not alone in worrying about telling others about this. This is a very common sort of reaction. And over 50%, I would say, 60 to 80% in some surveys report having experienced stigma with their Parkinson's. And certainly the certain things that are more visible feel more stigmatized, but there is this whole non-motor burden also that can be stigmatizing as well. So mental health issues are hugely stigmatized, and getting help for mental health issues is also stigmatized. And so often people don't want to admit that they have it. They don't come forward to describe these issues. And then they feel awkward about seeing a psychiatrist or a psychologist because they think that it's all in their head, and society stigmatizes this. There are certain symptoms that we see in Parkinson's that can look like people who are drunk or other, sort of things that might be stigmatized in society, like drug abuse or, alcohol abuse and things like that. And so people sometimes have a knee-jerk reaction, especially in our younger patients, to wonder, hey, what's wrong with you? Or is there something, what did you do? Did you just take a substance? Is that why you look like this? And I think Michael J. Fox himself was worried about some of that stigma. And he's, probably, one of our biggest Parkinson's advocates, but when he was younger, felt very much alone with his disease and didn't come forward for, I think, 10 years. And so again, bringing back that point that stigma is higher in people living with Parkinson's who are younger. And then, again, there's this sort of double sword of double stigma associated with aging and Parkinson's disease, and then Parkinson's disease and other intersections like LGBTQ, racial minorities, women, things like that. There's certainly intersections of stigma that can be pretty important to realize.
Yeah, and I think that Indu mentioned Michael J. Fox, and clearly before him, right? You think about when you heard the word Parkinson's disease, right? Most people never associated that with anyone who was younger, right? It was always, if you ask someone who gets Parkinson's, they say older people get Parkinson's, and you can see now how that's begun to shift. Michael J. Fox used his voice to begin to change that and begin to say, it's not just a disease of aging. We've got 10% of our population with Parkinson's who got it before the age of 50. So, and that's a growing population. So it's really important that as a group, we all have a common bond with Parkinson's disease, either working with it or having it, that we begin to increase the awareness of this, what it is, what it's not, as we move along, right? So Indu has kind of gone over a lot of this stuff, and this is one of those things that, you know, I think from a Parkinson's disease perspective, movement disorder docs spend a ton of time working on these motor features, right? And we know we've got Cinemat, carbidopa, levodopa, works great. But when you look at the research and you ask people who have Parkinson's disease, what are the things that impact their quality of life the most? It's very rare that we see tremor or dyskinesia or gait issues. It's always the non-motor stuff, the mental health issues, the depression, the anxiety, the loneliness, the fatigue, the incontinence, right? All of these non-motor things that are extremely common and really less talked about. One of the papers that we published a couple months ago looked at this issue, that how many patients come and are diagnosed with Parkinson's disease and not asked about their mental health, right? Think about yourselves when you go see your doctor. Does your doctor say, how's your mental health? How are you doing in this area and that area? It's important that those things are addressed, because those are the things that really affect how you feel in your daily life and the things that you're going to engage in. So I think seeing this picture of the iceberg is a nice visual to understand that so much of Parkinson's disease takes place in places that you don't necessarily see it in an individual, right? It's all kind of behind the scenes. So, you know, some of this Indu has talked about, you know, the social isolation and loneliness is a big deal. You know, I think that I think we all began to understand it more through COVID, right? Through the shelter in place became really problematic, and the mental health of our country has declined significantly from pre-COVID to now, with the rate of depression, suicidal ideation, anxiety, has all skyrocketed. Substance use, right, is up from pre-COVID. And I think a lot of that stems to people feeling lonely and socially isolated, not connecting with others. It's an essential part of functioning, right? It's an essential part of us being able to feel good about who we are. You know, when there's social isolation and there's loneliness, there's going to be stress associated with that. You know, that you want to get out and engage with people, but you don't feel comfortable. You know, you're tremor. Maybe you have to plan when you're going to go out because you worry about an off issue, breakthrough tremors, things like that. Incontinence, right? It's a big issue that people face with Parkinson's disease. And then the depression and the shame. How am I internalizing this stigma? What am I saying about myself, about my Parkinson's disease, about my tremor, about my dyskinesias, whatever it may be, and hopefully not going down this path of thinking to ourselves, I'm less than, I'm broken, I'm not worthy, my self-esteem's terrible, right? I think it's not uncommon for people with chronic illness to find themselves in that negative space. And it's just a negative feedback loop that just continues and continues. The more that I believe this stuff, the worse that my outcomes are going to be over time. Indu, you want to talk about some of these on here? Oh. Uh-oh. What's that? All right. Sorry.
Sure. So I think that, you know, Brad and I try not to do things unless there's something that we can actually do about them, because there's no point in outlining 10 things that are wrong with something and then not have any possibilities to fix things. So there's always sort of a, so what should I do about it? And I think with stigma, there are actually tangible things that we can work on. And, you know, we looked at that balance figure with the negative things that were on the top, like loneliness, like stigma, uncertainty, and things like that. When we look at, you know, what are the things that are going to help with increasing resilience, increasing self-efficacy, increasing a number of things that are positive on the bottom of that to really improve quality of life. These are the sorts of things that end up time and time again kind of resonating. And so one of the main things that's important is to, first of all, get educated, which you're already doing here, coming to this seminar, and empowering yourself. So getting information. And if your physicians are not really knowledgeable, because there is a lot to know, and some of this is very new, bringing it to their attention and saying, you know what, I really feel like stigma has been a major issue for me. I haven't told anyone about my diagnosis. This is really weighing me down. Can I get some help? So it's not just about motor symptoms, even though that's the easiest thing for us to measure and treat, and we have the best treatments for that. There's again, this mental health burden is quite important to identify. So that's important. And so talking to your healthcare provider and really starting the conversation, as we talked about. And that social support is really a buffer for so many things in Parkinson's disease. We have a paper about trauma. And if you've had trauma before, social support is the main buffer for that. And so getting connected to things in society, perhaps through support groups, finding somebody who could be your Parkinson's buddy, or a mentor. And there's, many sorts of things like this in which through support groups, people can find matches to kind of have other people with Parkinson's help them along. If that doesn't work, this sort of concept of social prescribing. So we have a sense that I, as a physician, can write a prescription to sort of prescribe social connection for you if you're lonely, or if you feel stigma. And so getting out there to sort of have some connection with other people. And in order to not feel lonely, it's kind of interesting. There's 3 areas that need to be sort of fulfilled. One is the sort of intimate connection, sphere of connection, which could be the person in your home. The second is a sort of friend circle with people that are, your tribe, a few friends in the community that you can go for walks with and have outings with and things, talk about your problems with. And then there's a sort of societal or kind of connection where we have a community of people in society that share a passion or sense of purpose with us. And so for some of us, it might be, being a veteran and a veteran's cause. It might be something to do with bird watching or a sports team or, a religious organization, but really having those connections through something that you have purpose and meaning or joy through is important. And so each of these spheres is important to have some connection with, and having a support group leader or perhaps your physician or a nurse or social worker in your community who might be able to help connect you with things that might be happening in your own backyard is actually, very helpful to get those resources. So, ask and be open to meeting some people. And then there are some ways in which we can try some wellness techniques. So group exercise, for example, is great. Mindfulness-based courses or classes with meditation in groups or yoga in groups, breathing in groups, singing in groups, boxing in groups, all kinds of ways to get in groups and do some things. And there are even some online resources where you may not have to physically go, but you can kind of participate in some of this. And then, if you end up seeing a psychologist, you may be a candidate for getting some one-on-one treatment for some things, cognitive behavioral therapy, acceptance and commitment therapy. These are all things that are having increasing amounts of actually data and science coming out for helping depression, anxiety, things like that. And some of these can even be done remotely. So I think there's a lot of excitement about the future of how we can actually make a difference in this space. But I think identifying the problem and getting educated is the first step.
Yeah. And I think, it's important that, and Indu started with this, is have the conversation with your healthcare provider, right? It's important for them to understand what you're struggling with. They know a lot. They know everything there is to know about Parkinson's disease, but they can't read your mind. And if you don't share with them what's really going on, there's really not anything they can do to help. So I think that's an important first step, is to let them know that you're struggling and let them help guide you towards some of these resources. If you need to have CBT, go. It's great. It's effective. It's a super tool to be able to help us change the beliefs that we have, the thoughts that we have that are associated with our condition or things in our lives. So just know that there are solutions to this stigma issue, and it's not going to be fixed overnight, right? There's some societal stuff that needs to change. particularly with regard to Parkinson's disease. And I think we've talked about some of those issues, but there's just more awareness that needs to take place. And it's also important for you to become more aware of your condition, your loved one's condition, and things that can affect whether or not I want to engage socially, and to continue to do that. It's really important. I think that one of the things that we hear people say is, when I'm connected with a support group, I feel like there are things that I can do that I haven't been doing, right? I'm able to see that just because I have it, I see all of these other people who have Parkinson's as well. They're actively involved in boxing or yoga or whatever that may be. So I think we can get that vicarious encouragement through others. So that's really what we've got. We wanted to leave a little time at the end for questions. If you all have any, we'd be happy to try to field them. But that's all we've got, Casey.
This was very, very good. Such an important topic. Okay, I think there's a few questions in the chat to start off.
Yeah, try to stop my share.
Let's see, I can.
Yeah,
There was a comment. Actually, no, there were comments. Please, if you have a question, you can unmute yourself and ask it, or type it in the chat box, please.
Casey,
Yes.
it's Karen.
Hi, Karen.
Hi, I have a comment that being involved in the community since 2014 and in support groups since 2016, one thing that I kept running into as far as educating people was the facial masking. We would have new people come in, and whether it was a person with Parkinson's or a caregiver, one of the comments in follow-ups after the meeting would be, but they all looked so sad. And yet the people in the support group that I knew were not sad. This could be one of the things that is getting in the way of people understanding it's just a manifest in the disease.
Yeah.
And if you get Mr. Smith started talking about the Steelers, he may actually start smiling and become a lot more animated. But people are always assuming that the expressionless face is an indicator of how they feel. And I just wondered how the experts or anybody else here feels about that. If we can tell people, don't go by the face, you know.
Yeah, that's a great point. And, we talk about that a little bit in this paper that we published, that even from a healthcare provider perspective, there's some literature that talks about the impression that the healthcare provider has of the patient with a masked face, that they're not cared, they're disinterested. And again, this comes down, I believe, to an educational component, that it's one of those things that I would be shocked if you ask someone, what do you know about Parkinson's disease? And they say masked faces, right? I mean, most people aren't going to throw that out there as something they know. And so it is one of those things that occurs very commonly. And you all who are around people with PD realize that. But again, that's an educational component that we have to do a better job as a Parkinson's community of being able to share that some of these other symptoms that are less commonly talked about are actually problematic and create issues with social inclusion, right? When you're out in public and you interact with people and they see this facial expression, do they avoid? Do they not approach? And how does that affect us? Indu, any thoughts you might have on that?
Yeah, I mean, I think the masked face is, a difficult thing. And then the other thing is apathy too. So when you combine the two, sometimes people really look like they're completely not interested at all. And, family members will say, like I have a number of people living with Parkinson's and their caregiver will say, I take him out to this really important dinner and I want him to be socializing with my friends, and then he just looks so bored, and I'm embarrassed because I'm like, but it's really that. And then, the person will be like, actually, I'm not bored. I'm just sitting there listening to people. And sometimes there's an additional hearing issue or speech issue that can also affect the communication. So I think, being honest about these things and trying to help plug in with, various types of folks that might be able to help with some of these things. So if it's, wearing your hearing aid, trying to, use, some speech therapy to try to project more, possibly even just saying, hey, grandpa has, something, and he may not look that interested, but he really is interested. Just give it a try, just sort of right off the bat, being honest about things sometimes is really the best policy. Once you put it out there, it's just, there it is, and everyone knows, and you're not hiding things. And I think, often hiding things and worrying about what everybody else is thinking. I've had literally patients hide the disease from their closest family members for 10 years. And they just go around waiting for the day that somebody's going to discover this. And then they're like, oh, well, what am I going to say then when my son finds out that I had Parkinson's for 10 years and never told him? Well, maybe you should include him earlier on. And, I think it's always better to not feel alone, not feel like you're hiding things from the people. So every minute of every day, you're sort of just feeling this extra weight of, these cover-ups and kind of sort of lying, and it's just a lot. So I think, I always try to get people to just tell their loved ones and try to include people, be honest, and educate around the fact that, yes, I may not look like I'm interested. It's just a facial thing, but I'm actually, here's what I have to say. And up here, my faculties are 100%. In fact, they may be better than anyone else at the table. So, I think it's really just about being honest, and then, trying to participate, and not isolate and exclude yourself.
Bernard, I see you've got your hand up. Good to see you.
Thank you. Yeah, and it's good to see both of you. I'm excited about this conversation. For those of you who don't know me, I have been an advocate in the Parkinson space very actively for the last 3 years, but for a while. But the key is some of these issues that are being talked about today. So first, I want to thank you two for the work you're doing, because you're leading right into what our advocacy work and our work in the community has told us. And so the first observation I want to make, and then follow with the question, is number one, I think part of our biggest challenge is changing the priorities of education. And I mean it in this sense. Right now, the focus in PD education is telling people all about the science of the disease. And so if you go to most sites, websites, or most educational materials, all focused on PD, the medical. But yet we're talking about quality of life things. And many of the things we're talking about are not the technical medical stuff. They're quality of life stuff. And it is a difficult challenge to convince many of the organizations we're trying to work with to change, to balance their priorities and put more of what we're talking about here in quality of life up front and less of the science. Okay, so I know about alpha-synucleins, but that doesn't help my socializing problem. That doesn't help my quality of life. So question number one is your recommendations for how we in the community can help reorient some of this, so that when we next time look at their iceberg slide, we have more of the things that are really important to us up at the top, and fewer of the things in medical, which they're more comfortable with, and therefore they push for to the top. So that's question one. What can we as a community do to sort of rebalance things? Yeah. And then the last observation relates to, are we going to just have to do this ourselves? No, basically get out there with each other and do the education, because there is a challenge. And I'm going to make it very specific to the diagram of the old white man. That's a very effective fundraising tool. And if you start to make some of this information, if you start to change the image, and I'm not convinced that if people believe that you're not going to die tomorrow for Parkinson's, that some of the funders will continue to fund it. So that's just the, a side observation. So the two questions are, what can we do to rebalance? And the second is, what do we do about this dilemma between the things that support fundraising and the things that support the community?
Yeah, you drink our Kool-Aid, Bernard.
Yeah,
One of
I
the
made
things,
it.
this is one of the things that drew me and Indu together, is that we have this common thought process of there's a whole lot more things going on in the world of Parkinson's patients than movement, right? And when she and I met and we just began having our early conversations, it was about these issues. It was about depression, apathy, anxiety, fatigue, all of these things that we're not necessarily talking about in the doctor's office. And so we began saying, what are these papers that need to be written to increase awareness? And that's kind of been our goal, as we've been going paper by paper, issue by issue, saying, why aren't we talking about this, right? This is a big deal. And I think the other thing that you hit on the head, Bernard, that's critically important to understand is funding, right? I can tell you from trying to apply for grants, trying to get grants that are specifically looking at quality of life in the world of Parkinson's disease is really challenging, right? They want to look at drugs and they want to look at biomarkers. And I'm all for that. I think those are great things. But my idea is, why don't we look at things that can help someone live a better life today? And those are the things that that Indu and I are really focused on. And I'll let Indu kind of chime in there as well.
Yeah. So in the interest of time, I think we have like 3 minutes left, but real quick. So I think, yeah, I mean, I think we've been listening to people living with Parkinson's and their voices and their caregivers' voices as well. So that's important. Number one is listening to you guys and hearing what you're saying, really, and then taking that and trying to do something about it. So for me, I think it's not all going to come from just neurologists. It's going to come from, multidisciplinary sort of look. What are all the lenses that we're needing to look at this? So psychologists who've done this work and psychiatrists. So Greg Pontone is a psychiatrist that works with us. So we have, some different sort of lenses to try to tackle the same problem and to break it down and then say, what can then we do constructively? And it's often not a pill. It's going to be, working through some of these wellness strategies and working with the psychologist. I think that's, nobody pays for that though, right? Well, no drug company is going to pay for this, or, device manufacturer or test maker who's going to bill you for a, biomarker test or a scan or something like that. So we have to understand that, the industry is not going to support this stuff. So we have to really, it has to come from within. We are writing the papers and we're trying to kind of get, the papers out there so that people can refer to them and say, hey, look, there's a paper, here's the diagram, here are the words, take this in and let's teach around it too. All the diagrams that we make, we try to make so that people can learn, we can teach our residents and fellows and medical students around this. So I think that's important. I do see that there's a comment here just real quick. Somebody had said that they wanted to find out about spouse is not ready to share a diagnosis and makes it difficult in many areas for both of us. How can we encourage him to be honest with others, starting with family members, or will that time come? I mean, I think continuing to just say how much stigma can affect people, how much the sort of hiding, the extra weight of things, of hiding things can affect people. I think once people have finally let the cat out of the bag, they often feel a huge sense of relief, and it can actually be a lot better on their mental health. So I think, I've seen that time and time again, certainly not, taking somebody's confidence and breaking that, is important. So letting the person come to that by themselves is really important. You can't be, pushing that or telling other people on their behalf. So, but I think, working with the psychologist also may be very helpful. And I think we're out of time, but thank you for the great comments in the thing here as well. Appreciate it.
Thank you again, Dr. Subramanian and Dr. McDaniels. This is such an important topic, and we hope to have more webinars focused on the non-motor symptoms in particular. Thank you all.
Thanks for having us, Casey. We enjoyed it.
You're welcome. Perhaps we'll see you on Friday. Bye, everyone.